Assalamu alaikum. I'm Dr. Ahmed Lutfi. I'm a senior consultant obstetrician and gynecologist. I've been practicing in UK, New Zealand, and in the Middle East. This is case number 8. It is a case of pain and or bleeding and or fetal bradycardia in labor. Case summary: woman in labor with previous cesarean section. She's showing sudden constant abdominal pain. First thing to come to my mind is ruptured uterus. Previous wound or previous cesarean section scar dehiscence if the patient has constant abdominal pain. Vaginal bleeding in labor with previous cesarean section. First thing to come to my mind is dehiscence of previous cesarean section scar. And this patient showed also a hematuria. CTG, fetal monitor, showed prolonged fetal bradycardia and loss of contractions. This is a case of ruptured uterus. On examination, the uterus soft, fetal parts easily palpable, and the head is high in the pelvis. We may not see all of these things, but if I have sudden constant abdominal pains with patient in labor with previous cesarean section, first thing to come to my mind is previous cesarean section scar dehiscence. If we have vaginal bleeding in labor, first thing to come to my mind, previous cesarean section scar dehiscence. Prolonged fetal bradycardia, loss of contractions on CTG with patient of previous cesarean section, or even if there is no previous cesarean section, this could indicate uterine rupture. The diagnosis, as I said, uterine rupture. The clinical, it is a clinical diagnosis. This is a clinical diagnosis based on maternal and fetal findings. Risk factors of uterine ruptures in labor or in pregnancy. Previous cesarean section is a major risk. Previous cesarean section scar is a major risk of ruptured uterus. Induction with prostaglandins increase the risk of ruptured uterus 5 times. Augmentation with oxytocin increases the risk of ruptured uterus with or without previous cesarean section scars. We have to tell these findings or these epidemiologic figures to the patient, because the patient has to do or to give an informed consent. Any previous scar in the uterus, like myomectomy, increase the risk of ruptured uterus. If there is no progress in labor, no progress in labor, especially with oxytocin, this increases the risk of ruptured uterus. Sometimes trauma causes ruptured uterus. The complications of ruptured uterus are maternal or fetal. Maternal, massive bleeding, massive hemorrhage, and hypovolemic shock. Most of the time it ends by hysterectomy and is a life-threatening condition. Fetal complications are severe hypoxia, stillbirth, or neonatal death. The management of this case: immediate resuscitation with IV fluids and blood transfusion. Call obstetric consultant and all senior staff, anesthetic, neonatologist, and theater staff, and emergency laparotomy to deliver the baby, and repair of the uterine rupture if it is possible, but if it is largely extended, hysterectomy could be much safe option. The key points of this case: we need always to consider classic signs: continuous pain, bleeding, loss of contraction, abnormal CTG, and I want to mention that the even decelerations could be a first sign of previous cesarean section scar dehiscence. And hematuria, all of these classic signs of ruptured uterus. Occurs most commonly in trial of labor after cesarean section. It requires immediate surgical intervention. This case carries high maternal and fetal morbidity and mortality if delayed. Thank you. This is the end of the presentation of this case.